you. Good morning. It's nice to see so many people. This is amazing. We have over 100 people in the room. And just think, several of you will live to be 100 years old. A couple of you will live to be more than 100. And maybe one of you will live to be 105. I have a patient turning 105 next month, and another one 104. So I do work with Kupuna in long-term care facilities at Leahi and Malohia, and also was a clinician at Kaiser for 25 years. I'm a geriatric nurse practitioner. Some of you may not be familiar with that role. I won't talk about that today, but I do want to share and reflect on some of the discussion that's already gone on. So I'm going to give you some sage wisdom. I always like to have, a kind of a concept of how I'm going to present some material. There's so many things to talk about in aging, and I'm also going to talk a little bit about medications. And I know you've already had sessions about advanced directives and medications, but I'm going to pull some of that together because these are things that I work with very, very, very often. So the S in SAGE stands for stay serene. That's not always easy for some people, and there's many challenges as we age. We do have to adapt to some of the changes with aging, and that's just a fact of life. I don't run anymore. I used to like to run, but I'm sticking with my swimming at this point. So maybe you can't be a runner anymore either, or play tennis, but maybe dancing is something you can do. And I'll talk more about swimming. I have a little bit of disagreement with Satoru about walking being the best. Walking is a great exercise. It's very convenient, but I think swimming is the best. And I know you've already talked some about advanced healthcare directives. This is something that I deal with down the road every single day of my life. And it is very important. That some of the things that I see that happen when this is not done is very sad. Even when people do have advanced directives, I have to share, an example which has unfortunately been repeated several times in my career recently, where people that do have directives and they do have a terminal irreversible disease, such as Parkinson's, and then another catastrophic thing happens on top of that, and they come to us in these facilities with a feeding tube and maybe a trach, and they're no longer able to eat or speak with us. But the family's interpretation is that these directives don't apply unless they're brain dead. And sometimes it's very unusual that people are completely brain dead after a stroke. It can happen, but that's actually fairly unusual. Many times there's problems with speech and eating function, and they really cannot communicate anymore. But you can see that glimmer in there. They may be able to communicate on a very minimal level, but if they already have multiple chronic diseases, what we see is they really suffer. So it's really important that you talk to your decision makers who are going to make decisions for you when you can no longer, about what it really means and what your values are. And again, if you have a deep, durable power of attorney for health care and it's your spouse, please consider having an alternate that is in a younger generation, because many times these documents are going to follow you for 30 years. And sometimes your spouse dies before you do, unexpectedly. Okay, so here's kind of the example. I like to make fun of it. It's very sad when we see this happen, but an elderly couple, they're watching TV and talking about these things, and the Mr. says, "Just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, just unplug me." And Mrs. says, "Okay," and she unplugs the television. Okay, what the point is, they're really not paying attention to what this means, and especially around what a vegetative state means, or brain dead. You don't have to be in a vegetative state to, in fact, and if you're in a vegetative state, you probably won't be suffering. But if you're not in a vegetative state and you can't speak to people and you can't eat and you have pain and you have contractures, you have suffering. And that's really very difficult for some family and for the staff that are taking care of you to deal with. Okay, so Tara also mentioned a little bit about, the question of, think about what are you going to do in the future about where you're living. If you have a nice big house, you've been there for many years and you want to live and die there, That sounds like a nice plan, but it doesn't always turn out so well. Especially when I worked in outpatient, when we see people that are still alone, they're in these big houses, their support systems have died off, and they're not doing so well, and they're not eating well, they're depressed, and some not so great things happen. We've gotten some of these people into other options, and they can really thrive in other places. So if you have the money to come and hire people to take care of you at home forever, that's really great. But most people aren't in that situation, and you still may be socially isolated in that situation. I've had a humbling experience in the last week. I do a lot of swimming, but I've never had an ear infection in my life until this week. And suddenly, Wednesday, as I was driving to work, I lost most of the hearing in my right ear. Now, it's been identified as infection, although I have no pain, and I'm hopeful that that will come back. But the experience in the meantime has been humbling to see what it feels like to not be able to hear well. So that's one adaptation. So there's no one size fits all. It's just something you need to think about and know about some of the options in our community. I think the continuing care retirement concept is really a great one. We have some of these in Honolulu. We have one at Kahalanui. We have Arcadia and Pohainani. Those are the only 3 places that really fit the concept of a continuing care model, where you can move in your same location, but you can move through different levels of care, from independent living to assisted living to maybe care home level and extended care or skilled care. We have a couple of other places where you can go into congregate living or independent living, but they don't have all of the levels, and that can present some problems. Assisted living is one. We have a lot of assisted living places, and that is a great model, but that doesn't always fit all your needs forever. So keep that in mind. And consider transportation services where you retire for when you can no longer drive. If you're thinking about moving to a neighbor island, that's where it can be most challenging. Some people really haven't thought about that, and it's very hard to give up. My own father had Alzheimer's disease, lived in a rural town. My sister was there, fortunately. But as it became more and more of a problem, and I had to recommend to my sister one day that my father seriously no longer drive. It was not an option. I was very sorry that I was so far away, but that really had to be dealt with. And she didn't know what to do, because she didn't want him to stop driving, because then she'd have to drive him everywhere, and they didn't live together. So I suggested we set up a taxi service that he could just call, and we would have an account. And she didn't think that could be done, but we did. And we had the bill sent to my brother. So we just told my dad that it was free. Again, back to the exercise, I think this is really important. We do have a lot of adapting to do as we get older, and sometimes what we were doing before doesn't work anymore. For example, running. We're having a lot of ex-runners join our swimming club and join us in ocean swimming. So that's good, but it's a challenge. So if you haven't been swimming at all before, you might want to start thinking about doing it now. Some of the medical programs with your Medicare coverage actually have a benefit for membership in the YMCA or some of the other gyms. So think about that. They do require that you use it or you lose it. Okay, I want to go back a little bit. Before I talk about medications per se, I want to respond to, it was good I got to hear Dr. Hinshaw's program this morning about vaccines. One thing I want to mention to you about the Zostavax, which is the herpes to prevent shingles, this vaccine is covered differently than your other vaccines. Your influenza and your Pneumovax vaccines are covered under Medicare Part B, and you usually will never see any kind of a copay for those. It's not true with the Zostavax. It's covered under Medicare Part D. Probably most of you have Medicare. Does anyone here not have Medicare? Do you have federal retiree insurance, or you're too young for Medicare? That's probably okay. So you may not even be eligible for that anyway. But most of you are going to have Medicare at the time it becomes an issue. And because it's covered under Medicare Part D and it's an expensive vaccine, what I've learned is if you already take a number of other medications and you end up on your donut hole where you don't have coverage, which I know it's shrinking a bit, you're going to get a very expensive bill. So it depends on your coverage, but if you do it at the beginning of the year, you won't have to see that bill. It's about a $200 vaccine, depending on your plan. Anyway, back to medications. This is so important because many of you are taking multiple medications for chronic diseases, and that's going to be added on to. And these medications can be responsible for many of the hospitalizations that occur. Just this week, I've had 2 patients that had strokes and their blood pressures weren't very well controlled. They controlled it in the hospital with all the right medications. But as they come to us and they're no longer on IVs, their blood pressures have plummeted and they don't look so good. And the staff will come to me and say, it looks like they had another stroke. Actually, they just need their blood pressure medications adjusted again. So, and that can happen to people at home too. You get something at the hospital, you go home, and you're taking all these medications, and you end up with some problems. There's only one website I want to throw at you today, and that's this one. The American Geriatric Society.org has some wonderful information for consumers as well as providers. And the beers list is not what you think. It's not about beer, but it is a list that has been compiled over years, and it was started by Dr. Mark Beers, so named the Beers list. It has been updated several times, and there's another update coming out either this year or next year. And this is a very evidence-based list. They're really looking at the research. It used to be just a list that we thought were problems, and more research has been going into looking at these drugs. One of the things on this website that you really would want to look at, besides just the list itself, is there's a pamphlet called the Consumer Guide. So that if you find that you're taking any of these drugs that are on the what we call potentially inappropriate list, then you want to go to your physician and talk about, is this the best option or are there other options? Sometimes there isn't a better option depending on your constellation of chronic diseases. But sleeping pills, I think, are a big hit. I really have rarely prescribed sleeping pills, and I think that the best sleeping pill is non-medication. But maybe if you have pain, you need to try Tylenol, plain Tylenol, before bedtime. I know sometimes if we have pain at night, we're not sleeping as well. But there can be some real problems with insomnia as we get older, and it may be related to a medical problem. So that really needs to be investigated. And it's also very important to realize that our sleep patterns do change as we get older. We have longer and more frequent awakenings at night, and we may be just fine the next day as far as function goes, so consider that. Sleeping pills do carry some pretty significant risks, especially as we get older. They can be some cognitive impairment, and there's some new information, especially around the drug zolpidem, Ambien, that there are some cardiac issues as well. And if you do take sleeping pills, it may change the quality of your sleep. So even if you get more sleep, it may not be as good. And again, physical activity is probably one of the best things, and regular schedules, and avoiding excessive naps during the day. Anticholinergic drugs. You can find more. There's a list on the American Geriatrics site with a lot of anticholinergic drugs. But I'm going to tell you the most prominent things that you're going to find yourself. And those are the antihistamines. Over-the-counter drug, cold drugs, all have some kind of antihistamine in them. You really have to look at the labels. I mean, there's so many combination products over the counter now, it's dizzying. And you can actually get into trouble with some of those medications in there. So you should always consult your primary care provider about what you're taking over the counter as well, especially cold medicines. So Benadryl is one of the prototypes. It is the most anticholinergic drug I can think of offhand. It is a great drug for having, if you have a drug reaction, you're having terrible allergic reactions, it can be a life-saving drug. But using it for allergies or sleep, especially in the older population, I think is a very bad idea. People can actually hallucinate from it. I'm going to talk more about the anticholinergic side effects in just a minute. Tylenol PM, a lot of people don't realize it's got Benadryl in it. So plain Tylenol is the better option. Drugs for overactive bladder. This is very common in older women, and there are other things that we can be doing that are non-drug related, or you may need to actually have some further workup done by a gynecologist or a urologist. So be very cautious with those drugs. The older ones are more anticholinergic. There are some newer ones, but again, you need to really identify what the problem is. There are some antipsychotic medications probably not very many people in this room are taking these, but you may have family members, and olanzapine is one of the most anticholinergic of those drugs. And then if somebody has Parkinson's disease, sometimes they're on drugs that are very anticholinergic, and it can make them even more confused than just with their Parkinson's disease alone. A lot of times they'll give them something that for the tremor that's an anticholinergic drug, and that can again cause these side effects. The side effects that you really need to be worried about are, so it's causes sleepiness. It also causes dry mouth, constipation, blurry vision, and frank hallucinations I have seen in many older people, and not that old actually. Depends on how many other drugs you're taking, how many other anticholinergic drugs you're taking, and what your cognitive status is as well. Gastrointestinal drugs. Everybody's had a little heartburn sometime in their life, and there's a lot of things over the counter that you can buy, including what we call proton pump inhibitors. These are very great drugs when they're used correctly. And these are things like omeprazole, or Prilosec is the brand name, lansoprazole, pantoprazole, and so forth. But there really should be some very clear goals and guidance, and share this with your physician or your nurse practitioner. These drugs can really change the acidity of the acid in your stomach, which is why it helps your heartburn so much, but it can also cause some other problems in terms of absorption in your stomach. These drugs are also implicated in increased rates of infection, and especially C. difficile, which is one of those what you call superbugs that we're seeing because of resistance and increasing use of antibiotics. Clostridium difficile causes a lot of loose stools, and in some cases, what we call it pseudomembranous colitis, and it's actually a very painful situation. And then we have to use other drugs to treat that. Eating problems. Most of us spend most of our life worrying about losing a few pounds, or more than a few pounds. But as people get older, it seems to be the opposite. In my practice, we spend a lot of time worrying about people that are losing weight. You know, is it just because of their teeth? Is it because of their cognition? Is it because they have a cancer? You know, what's the worst thing it can be? We're always thinking about. But many times, it's because of the drugs that they're taking. Anyway, so weight loss, there are over-the-counter supplements. I would be very, very leery. These things have ended up usually being a problem with pretty severe side effects affecting the cardiac system, and we've seen some strokes in some cases. I would advise you to avoid appetite stimulants, whether it's for you or maybe you still have some parents in this room or aunties or uncles that are elderly. And I have been asked many, many times in the nursing home, Valisa, can you prescribe Megace? Please, Mrs. N isn't eating very well, or she's not eating at all. That's really not the approach we want to take. These appetite, so-called stimulants, first of all, it's not approved as an appetite stimulant for the elderly, and the evidence is not very good, and they do carry some significant risks. We really need to look at, first of all, what medications are they taking that can be causing problems, and there are many. So that's something you can always look up, but some of the drugs that people are taking for Alzheimer's disease, such as donepezil, galantamine, or rivastigmine, those are usually my first hit. Those have a lot of GI side effects and can be causing impaired appetite. Many antidepressants are anorexic. Most all of them, except with one exception. And there's a number of other drugs that we would look at, including some cardiac drugs. And then again, what's the underlying problem that they're not eating? And if it's advanced dementia, again, we need to look at medication regimens, hand feeding, what's the environment like, and really spend some time on that. Okay, and it's very emotional when your your family member doesn't eat anymore, and we don't want them to starve to death. And that's not exactly how people with advanced Alzheimer's die, but eventually they do. Okay, medication reconciliation. We're almost done here. This is a concept that, I know it's probably very annoying when you go to the doctor's office and every single time they ask you, what medications are you taking? And you wonder, well, don't they know it's in my record? But it's really important. There are so many mistakes that can be made along this process. We really need to take a back at that. Do bring a list, a detailed list, or bring the bottles themselves. Do bring the over-the-counter medications that you're using. And please remember, no, your providers do not remember exactly what you're taking. And they cannot tell, and even with the electronic records in the outpatient setting, they can see everything that's been ordered, but they do not know what you are taking. They do not have authority to discontinue some drugs, or they wouldn't do that if you're seeing some specialists. And no, the computer doesn't know what you're taking. I'm just going to quickly tell you this example of a patient that this happens a lot of times. An 88-year-old female with high blood pressure and Alzheimer's dementia is living in an apartment with hired help. Her daughter reports she's falling down a lot and her blood pressures are sometimes less than 90/60. That's pretty low. In the evening, her medications are losartan / HCTZ 50/25 milligrams once a day, hydrochlorothiazide 25 milligrams once a day, metoprolol tartrate 25 milligrams twice a day. This is a real case that a friend of mine brought to me. And I asked her what the medications were, and she texted these medications to me. So anybody right now see a blaring problem with this list? Okay, what is HCTZ? Hydrochlorothiazide, yeah. So she's getting a combination drug, losartan, which is an angiotensin reuptake blocker, very important, it's a really great drug, and hydrochlorothiazide. She's getting 25 milligrams of that, which we never use more than 25 milligrams in an elderly patient. And she's getting hydrochlorothiazide, another 25 milligrams. And this happens when you go to different providers or you see different providers or it's dispensed in different places. And then the metoprolol tartrate is also a blood pressure medication. So, I mean, eventually we got her to somebody that really cleaned this list up, took her off all the diuretics, actually, and she's not falling down anymore. So, be healthy, live long and well, and do find your passions. This is my passion, swimming, and we do have some fun when I do a lot of ocean swimming, and I have a friend that's really getting good at photography, and she has all these great ideas. This is an upside-down picture that we've decided we're going to perfect this technique, where we're all upside down and the photographer's upside down, and it looks like it's right side up. Okay, thank you.